Hi, my name is Sivaraman, and I'm a PhD student at Carnegie Mellon University. Together with my colleagues at the University of Pittsburgh and UPMC, I'm excited to share our work, Ignore, Trust, or Negotiate, Understanding Clinician Acceptance of AI-Based Treatment Recommendations in Healthcare. AI in healthcare has the potential to save clinicians time and effort, as well as improve outcomes for patients. And we've seen recent studies in the HCI community that have demonstrated how we can design AI-powered systems to help clinicians, for example, make diagnoses, retrieve relevant information from health records, or make prognoses about patient survival and mortality. But one potential limitation of the applications that we've studied so far is that they typically assume the correct decision is known or could easily be determined or verified by a good clinician. And the algorithm then just needs to replicate what that good clinician would do. This has the potential to work well when the goal of the AI is to simply automate time-consuming and expensive clinical work. But what about cases where the decision isn't as clear-cut? In this work, we studied treatment recommendations, and in particular, treatments that are made multiple times over the course of a patient's trajectory. It's more difficult to determine what the best decision is in these cases because future treatment choices can confound the effects that we measure for past ones. And this is why most approaches for treatment recommendations so far tend to rely on expert-curated guidelines. But AI has huge potential to help in these types of decisions because it can mine patterns from historical data that clinicians might not yet be aware of. An important context where these treatment recommendations can be helpful is sepsis, a life-threatening condition in which the body's response to an infection, such as, for example, COVID-19, causes damage to vital organs. And sepsis is one of the major causes of death in hospitals right now, so there's a huge potential to save lives if we can improve the way we find and treat it. Most of the research on AI for sepsis has focused on diagnosis, or identifying and prioritizing septic patients. Once the patients are diagnosed, though, there's another set of challenges around treatment. And there's a small number of treatments that clinicians typically apply, like antibiotics, intravenous fluids, and drugs called vasopressors. But because there's so many different ways sepsis can present and there's relatively little consensus on best practices in terms of timing and dosages, current treatment decisions are often highly variable, uncertain, and complicated. Now, there have been some recent machine learning approaches that have been shown to lower mortality if their decisions are followed. However, these algorithms have only been evaluated on historical data, and to our knowledge, they've never been tested with real clinicians. Moreover, this task is quite different from previous work in HCI because even expert clinicians don't necessarily know what the right answer is, and treatment decisions can vary along a lot more dimensions compared to a simple diagnosis. So that led us to ask the main research question that drives this study, which is how do clinicians interact with and decide whether to rely on AI-generated recommendations for treatment? The basis of our study was an algorithm called the AI Clinician, which was developed and published in Nature in 2018. This algorithm used the MIMIC dataset, which contains around 30,000 patients with sepsis, to learn which treatments to apply in which patient states to minimize the expected mortality. And although there have been some technical advances on this problem since the AI Clinician, we chose it because it was highly influential in the critical care community, and its relatively simple approach could make it easier for clinicians to understand how it works. But before we could show the AI clinician to a human clinician, we first needed to be able to visualize patient cases and understand what the model was recommending for them. So we built this interface, which we call the AI Clinician Explorer. And what this interface shows is for a given individual patient, all of their demographics, prior history of illness, vital signs, lab values, ventilation settings, prior treatments, and model recommendations. And if you scrub the slider in the top left, you can see how these values evolve over the course of the patient's stay in an intensive care unit. So we were able to use this interface to select cases where the model's recommendations deviated substantially from the clinician one. And these served as the stimuli for a Think Aloud decision-making study with 24 practicing clinicians across a range of experience levels. We showed participants 4 variants of the interface I just showed, where each variant was paired with one of 4 patient vignettes like the one you see on the right. For each patient, participants had to select a treatment strategy for the next 4 hours in terms of IV fluids and vasopressors while talking through their decision process aloud. The 4 visualization conditions consisted of the left half of the interface remaining constant and the right half was replaced with either no AI at all, a text-only recommendation, a text recommendation combined with a feature explanation chart, or the text recommendation plus an alternative treatment chart, which consists of 5 possible options and the predicted treatment value of those. So now let's talk about some of the key results of our study. First, how did participants perceive the AI as influencing their decisions? When we asked participants how the AI affected their confidence, they rated that the feature explanation chart made them significantly more confident than the text-only condition, and slightly more, but not significantly so, than the alternative treatments chart. We saw similar results for the usefulness of the AI. So it appears that, consistent with prior literature, when we provide this explanatory information to clinicians, they find this AI more helpful and confidence-inducing. However, if we look at whether these clinicians agreed with the AI recommendation or not, we saw no significant differences across the visualization conditions. So although the visualizations were affecting participants' perceptions of the tool, they didn't seem to affect whether they ultimately agreed with the AI. So what factors did affect whether they went with the AI or not? To find out, we conducted a qualitative analysis of the Think Aloud transcripts for every AI-assisted decision. And what we found was 4 distinct behavior patterns of how the AI was used. I'll talk about 2 of them in this talk and refer you to the paper for the other 2. The first group, which we call Ignore, for these participants, recommendations didn't substantially influence the decision-making in any case. Instead, participants evaluated the tool relative to their own judgment, saying things like, she may be hypovolemic, but certainly I wouldn't start a pressor on this patient, and IV fluids, I disagree with that as well. So these participants got less value out of the AI because they were holding their own judgment as constant. The second group, though, which we call Negotiate, exhibited a more mixed form of reliance. But instead of overall agreeing or disagreeing with the recommendations, they prioritized certain aspects of each recommendation to follow and then deferred others to their intuition. So for example, one participant agreed with an overall treatment plan presented by the AI and said, I don't necessarily disagree, but I would start with the fluids and then I would escalate to vasopressors if there was no response. And these decisions to follow, reject, or defer particular aspects of the recommendations were often moderated by how severe they perceived the patient's sepsis to be, as well as the explanatory evidence that we provided. Participants also shared some broader perspectives on the AI during our sessions. So first, many participants said that they would like to go into the room with the patient and conduct some exams, like doing a passive leg raise or an ultrasound to see whether the patient would respond to particular treatments. And they perceived this information as more reliable than anything the AI had access to. Second, clinicians expected the AI to replicate care practices that they had been taught, like administering fluids before escalating to vasopressors, even though deviating from those guidelines in some cases has been shown to improve outcomes. And finally, participants agreed that they'd want to see rigorous and credible validation of the AI before they could trust it, even in this simulated case. For example, if there was a study in New England Journal of Medicine that said that this tool could improve outcomes, then I would say it could be kind of useful, which poses an obvious challenge to how we can reliably validate these tools. We discuss many implications of these results in the paper, but for now I'd like to briefly describe one of them. We initially approached the study aiming to design for human AI reliance as it's often described in the literature, where decision makers evaluate their understanding of the AI against their own capabilities and then make a decision about whether to accept or override it. But perhaps because these decisions are sequential and very complex, a more useful design goal may be to help clinicians negotiate or identify aspects of the recommendations to prioritize following. But the AI isn't formulated to participate in this type of negotiation. So a direction for future work could be to develop models that can decompose their recommendations into their most important aspects, as well as to design interfaces that can adjust the specificity of recommendations and conduct a negotiation essentially based on both user characteristics and the model's confidence. To learn more about other design implications and directions for future research, I encourage you to refer to our paper. But for now, I'd like to thank all the clinicians, staff, and fellow researchers who made this study possible, and please reach out by email or at the conference if you'd like to chat. Thank you.